we are here. We made it.
It's good
Portland.
to be here. Portland,
Portland.
Oregon, or Maine? Which
I know, right?
It could be either one. I really don't know.
A or B. It's just a little bit less of a flight for both of us.
I was sleeping, so I don't know.
Right. If it was in Maine, we would have been there already.
Yeah.
But we are already out here on the West Coast. You just got done with this great lecture that was talking about sacrospinous ligament, vaginal surgery, and of course, we live in this world of robotic surgery.
We do.
We do.
It's interesting because we're at a conference with urogynecologists, and we are all here trying to learn what's best for our patients, what's safest, what's most efficacious. And as a general body, during one of the debates yesterday, they voted off, on the first vote, the preeminent anatomical scholar in the universe
Right.
of the female pelvis when he spoke about what he would use for a vaginal vault prolapse.
He got booed off.
First person booted off the island.
Right.
And nobody knows more about pelvic anatomy than this man, by far.
Dr. Delancey.
Dr. John Delancey. And I felt bad. I felt like, well, this tells me two things. It tells me that, one, they don't know who John Delancey is. This general body is much younger than when I started.
Right. You and me both.
And they don't know who he is. They don't understand that when he says this is the best way to do something, you probably have to have a very good reason not to believe him and not to adopt what he's talking about.
Right.
But they voted him off first go round with the glamour of the robotic sacral colpopexy being the number one option for the crowd. Now, it told me a lot of things. It told me that we have a long way to go to get people to come back to vaginal surgery.
Yeah.
And I think what's lost in translation is they view the vaginal surgery approach as a Smith Corolla. Like, okay, if you're doing vaginal surgery, you're doing this. And that's actually not the case. The case is that we need to take all the great things about vaginal surgery, its safety, its speed, its efficacy, its ease.
Cost.
Cost, my God. And they
Right.
mentioned cost a couple times, but they mentioned it so quickly, and nobody seemed to care.
Right.
They talked about green waste, they talked about cost, and no, that didn't register on anybody. And rather than discussing safety and cost and all the salient things that we should be discussing, the seduction of the robot and the person presenting the robotic arm of that had a very polished presentation. So it was again falling victim to the sparkle rather than the reality.
Yep.
And so bringing the society back, or not necessarily the society, that's a little bit too much to handle or to bite off, but bringing back individuals who might say, you know what, that vaginal route that we became interested in when there were kits of polypropylene, and we abandoned when those kits went away, that wasn't such a bad way to approach prolapse. So we just have to cobble together for them simple ways to get fixation coupled with simple ways to get scaffolding into the patient.
Yeah.
And they haven't quite, and I say they, meaning as a group, as a society, as a subspecialty, we haven't quite grasped that we can look in that direction without actually telling you that robot's not good. The robot's great, but it's not necessarily the best. Another couple of things they missed about Dr. Delancey's presentation is he mentioned that the suspension of the sacrospinous ligament at 4 points and the whole concept of that being lost in studies, translation was again, I think, over everyone's head. More importantly, he also mentioned attention to the genital hiatus, or the opening of the vagina. So unless you're doing a robotic apical repair and then returning to the vaginal rest of the work,
Right.
you're not doing a comprehensive, complete repair. And again, that never really got the attention that it should have in that debate. He was just off.
Right. One. How long did he spend on his presentation?
You know,
5 minutes?
I think everyone got 3 minutes.
3 minutes.
And
Everyone got 3 minutes.
it's 3 minutes where
It's hard to summarize, 4 decades of work, right?
it, and I think
In 3 minutes.
part of Dr. Delancey's problem is that he's just so humble and gracious and brilliant, but he's not the kind of person that says, "Hey, look at me. This is the best way to do things." In the story,
Right.
and I think that unfortunately got lost. And again, literally, he was voted off the first suite.
Well, you're definitely one that has proven that this approach works. It works well. It works well for your patients. You're able to many times send your patients home that same day if they desire, right? Some people might have to travel, so they might want to stay over. And then at the same time, you've also gone down this path of being mesh free. So that's another uniqueness about it when we sit in this room and we've got mesh everywhere. Still.
Mesh is still everywhere, whether it's for slings, and if they could vote to have it put back in the vagina as an organization or as an industry, they would. And the reality is, it gave us an opportunity to say, let's take a breath, take a step back, and find out, rather than saying no scaffolding, let's find the best scaffolding.
Right.
And let's realize that reconstruction of the vagina requires fixation, requires scaffolding. Whether it's the patient's own scaffolding, or if it's biologic scaffolding we put in, which then turns into the patient's own scaffolding under remodeling.
Yep.
Those are questions that, as a group, we should be looking into. I don't remember seeing. I missed the basic science section this afternoon, but there is not a heavy presence of basic science looking into what is our best biologic, or more importantly, what the pathophysiology of constructive remodeling.
Yeah.
And then I'm going to put something in that's not actually going to be there because it's just going to induce the patient to replace it with her own tissue. So again, I think we're missing an opportunity with the vacuum created by the removal of mesh, even though it wasn't our society that removed it. It was the FDA, pushed by the lawyers, pushed by women who are harmed, that had it taken away. And I think as a society we objected to that because it was the tool that most people had, and we didn't readily replace it with anything.
Right.
I'd already made the shift, but I wasn't, I'm an army of one. So it's hard to sort of to all of a sudden be the option for everybody when the masses have their tool removed. And I have to say, there's a little bit of wandering in the wilderness still. So there's, as I said, there's still a bit of wandering in the wilderness as a group of specialists. Not everybody's kind of figured out, other than the omnipresence of robotic sacrocolpopexy, which, don't get me wrong, is a very excellent apical solution.
Right.
But it's only an apical solution. No matter how much we talk about taking that graft anteriorly or posteriorly, and you can take the graft posteriorly to the perineal body robotically or laparoscopically, but the reality is, once you do that, you may come to the realization that I'm now approaching the perineal body from an abdominal approach. Probably could have done that vaginally. Easier, safer, and I think it actually is actually really nice to hear someone say robotically, I could take that graft, that mesh, all the way down. Like, yeah, you can, and maybe we could just take that from the vaginal root anyway. Pay attention to general hiatus.
Yeah.
But if you just say, I want to do the apex robotically and then go down and fix everything else, I think I applaud that approach too.
Sure.
So biologic grafting has got to become the quiet storm of our organization. And we have to sort of pick off surgeons one by one to say, we've got to, the basic concept of fixation scaffolding, which is, they seem to have easily bought that when the kits were out.
Yeah.
Nobody questioned fixation scaffolding.
Right.
Fixation scaffolding. And now it seems to be like, you use mesh in graft in most of your patients. I'm like, when you were putting in that mesh, you didn't question that.
That technique.
Yeah.
Right?
You didn't question the technique, and you didn't question that all your patients using those kits got scaffolding.
Right.
So if I say, well, that was probably a good idea to provide fixation and scaffolding, as a group, let's look at the best scaffolding. And that's sort of, again, a lot of people being lost in the wilderness. And I think this conference has made me realize that we need to take a step back and say, hey, wasn't a bad way to go. It wasn't a bad way to do things from
Right.
the vagina.
I mean, you think about the number of people that put in, AMS Elevate, right? Because it was a very well-engineered, well-designed system in the right hands.
It was a brilliant system designed by Charlie, who's standing right over there. And I believe, so they tell me, I put more of those in all but one person one year in the country. So I have the sort of the dubious honor of doing that, but I also saw a lot of complications and a lot of results from that placement. But the concept of fixation scaffolding
Right.
was both brilliant. The anatomy was brilliant. Delancey, who, by the way, developed the PopQ system, was, again, we wouldn't even know how to talk about things without Delancey.
Right.
But looking at his understanding of anatomy and understanding the brilliance of the landmarks that we can reach from the vagina, there's no reason to lose that. It doesn't mean that you're with a Smith Corolla. It means that we're taking the best of the old, combining with the best of the new tissue engineering, and giving our patients the safest, least expensive outcome.
Yeah. And with a fantastic recovery.
Fantastic. We almost never have to discharge patients with narcotics. So,
Which is big plus, and means that you are truly taking the best approach if you can avoid those. And many times you don't even have a scar, right? I mean, it's the natural approach of fixing their prolapse to include both the anterior, posterior, along with the apical side of things, and
the perineoplasty.
perineoplasty.
And I think that, again, with the addition of, as natural orifice surgery, the addition of the ability to do laparoscopy transvaginally enables us to also approach the adnexa, because one of the arguments was, well, if I go robotically or laparoscopically, I can remove the uterus and the tubes and the ovaries, which are sometimes difficult to reach from a transvaginal approach unless you have vast experience. Most of our residents and fellows do not have vast experience with transvaginal surgery. But with the addition of V-notes or transvaginal laparoscopy, we can get adnexa in almost all our patients via V-notes.
Yeah.
So that concept of, that's a reason to go abdominally is no longer
valid. Right? Because now you have a solution where you can do a hysterectomy, and then now all of a sudden you've got that ability to grab that distance and let, vaginally / laparoscopically, do an oophorectomy or
absolutely
deal with any minor complications that they might be experiencing without having to open them up.
Yeah.
Right? Big positive there. So, any other interesting things about the show that we saw a little bit on? Saw some things coming out in biologics. We've seen some new players that have entered the scene. I feel like they probably have seen us and our success in the fact that we've been able to be, innovative in a time and a place when there really hasn't been a lot of innovation.
No, you guys were clearly never left the market and always held a hand up, say, hey, we're still here. You were there when mesh crashed. You were still there and didn't abandon the market. Some of the biologics that were available ran and scattered
Yeah.
when the mesh was pulled. And now we find that a lot of the major players are coming to market with their own biologics, understanding that the wave or the shift to the correct scaffolding has yet to be delivered to the general population because they haven't looked. So you guys have always been there, and with a great product with great results. So.
Well, we feel fortunate, that we have access to this technology, which started with heart valves, and now we have all these pre-cut shapes, all based on Dr. Delancey. Imagine that.
Imagine that.
Why would we do that?
Dr. Delancey.
You know? So if you go off of his anatomy and you create a pre-cut shape based on his, I think you're doing pretty good. All right, I think we
arts and grafts.
Hard to say no to that.
Yeah.
And of course, someone like yourself that has, hundreds and hundreds and hundreds of these of our implants, which we feel very fortunate about, and now we are actually in the process of collecting some of that data with Dr. Rose, and I think that's gonna give some of these women the confidence to be able to ask their physician to be able to request VNU as a viable option.
And you bring up a good point, because I think sometimes it takes bypassing the collective body of the organization in order to make change happen.
Right.
In other words, the pharmaceutical industry realized that a long time ago with direct-to-consumer advertisement.
Yep.
And having patients come in asking for, and you've done some direct-to-consumer marketing, which has actually been, I think, very successful.
So we just got done with we're still in a campaign. We just renewed. It was so successful that we said, hey, let's try it again through the holiday season, because you've seen patients that have seen the advertising in the mall, and they're interested in a mesh-free solution, and you've had women that have seen it directly, and I think you've also had sons and daughters talk about mom, right?
Yeah.
And like, hey, I saw this and I wanted my mom to come see you.
Yeah, we've had, again, the direct-to-consumer marketing is just another avenue that most of the companies that are servicing women's health haven't quite embraced at the level that I would expect. But it works because as a collective body, if we're not saying this is our favored approach, I think it's incumbent upon industry and individual surgeons to say, I know I'm not fighting against my organization at all. I'm only representing a relatively smaller arm of it, but having that arm available to patients as an option is all we're trying to do.
Right.
We don't tell anyone that they should not have a robotic sacrocolplex. I love the robot. I think, and I do mine with straight sticks, but it's a great procedure. It's just that everybody should know there are other options.
Yeah.
And that's pretty much what we're trying to do.
100%. And we're certainly happy to be partnering with you. Thanks for stopping in at our booth.
I see that
We get to hang out here in Portland and go grab some dinner tonight and enjoy the town and walk around and just be safe.
Be careful.
Just be careful. Be careful.
Good to see you.
Dr. Duncan, always a pleasure.
Likewise.